Okay, well, thank you. And this afternoon, we're going to talk a little bit about sort of more basic hormone concepts. Those of you who don't know who I am, I'm Bill Clearfield. I practice in Reno, Nevada. We've been doing hormone optimization for more than 20 years now, and things have evolved and to the point where we have it down to a pretty good system. I like to think of that we look at all of our patients through what I call a hormone-centric view, so that we look at all of the problems that show up at our door with that in mind. And we're looking for excesses and deficiencies, and of course, what we want is we want Goldilocks, not too much, not too little. So today we're going to talk about men, and tomorrow morning we're going to talk about women. So basic hormone replacement, or I like to call it this, but it's not quite so scientific. But nearly everything we learned about testosterone and pretty much hormones in general in medical school was wrong. No financial disclosures. Objectives, we're going to talk a little bit about just testosterone physiology, the basics of treatment, common problems and complications. I'm going to talk specifically about testosterone and the prostate, testosterone and cardiovascular issues. We'll talk a little bit about 5-alpha reductase inhibitors, aromatase inhibitors, and a couple of other things. And if we have time for a couple of case histories, we'll do that. Okay, before we even begin, I need you to keep this in mind. These are the physiological amounts of hormones that one produces at age 25, peak production on a daily basis. And keep this in mind. Testosterone, 5 to 12 milligrams per day. So when we give somebody a 200 milligram IM injection, 12 times 7 is 84. So we're giving them more than 2.5 times the physiologic dose with the 200 milligram injection. Now, sometimes we have to do that to try and keep it at a sort of a steady level, but these mega doses is where we're going to run into problems. Cortisol, 20 to 30 milligrams a day. So if you use hydrocortisone, Cortef, the non-fluorinated, not once a day cortisone, you really should have very little to no side effects, depending on what the issue is. Androstenedione, 3 milligrams per day, DHEA, 15 milligrams per day, and estradiol, 0.045 milligrams per day. So keep those in mind when you're dosing. Did you get that? Got it? Okay, all right. So testosterone, it is generated in the Leydig cells, and the Leydig cells is where testosterone generates. The Sertoli cells, these are the cells in the testes, is where sperm is generated from. So we're sort of working backwards here. So LH is our anterior pituitary hormone, stimulates the Leydig cells, so LH Leydig cells, to make testosterone. FSH, got that little S in there, Sertoli cells, this is where it generates sperm. So you can have an elevated LH and a low FSH, and you're going to have a lot of testosterone and no sperm. So that's what you need to know. Testosterone works on a negative feedback mechanism. There's a hormone called inhibin, which you can measure, but we usually don't, that either turns on or turns off the anterior pituitary to make LH and FSH. And there's another negative feedback that stimulates the hypothalamus to make gonadotropin-releasing hormone. And so from top down, the hypothalamus secretes gonadotropin-releasing hormone, tells the anterior pituitary to secrete LH and FSH. The LH stimulates the Leydig cells to make testosterone. The FSH stimulates the Sertoli cells to produce sperm. Testosterone biosynthesis, again, in the Leydig cells, and it's controlled by cholesterol. Okay, you know, that stuff we told everybody not to eat in the 80s and 90s. And if I go to a cardiology conference, then I think it's, what's the LDL now? They want it down to 55 or 50, 40? Yeah, and they say, well, I don't feel good. I got all these side effects that are hormone-related side effects, and they don't care. Right? Okay, but your cholesterol is good at 40. So cholesterol is on the outer membrane of the mitochondria, and the rate of transfer to the inner membrane is controlled by a protein-activating enzyme called steroidogenesis activator protein, or STAR protein, that initiates the rate-limiting conversion step from cholesterol to pregnenolone, and that is catalyzed by cytochrome P450. Testosterone has a half-life of 12 minutes, so it needs to be done continuously. This is the steroidogenic pathway, and we actually have a lecture on this exclusively. If you want that, this is sort of like the basic physiology. And usually we tell our students, if you're going to work on growth hormones, you need to know this. Okay, it looks pretty daunting, but after a little while, it gets to be pretty, you get to know it. So here's cholesterol. The rate-limiting step is this one here, cholesterol to pregnenolone. Pregnenolone will convert via 17-hydroxylase to 17-hydroxypregnenolone. Then 17-20-lyase will convert the pregnenolone and progesterone to DHEA and androstenedione to androstenediol to testosterone. The one we always hear about is testosterone will convert via aromatase to estradiol, and so we need to pay attention to that. And then here's that 5-alpha reductase also. But that's the rate-limiting step. Testosterone is responsible for muscle mass, bone formation, spermatogenesis, sexual dysfunction. The pathway down to via estradiol, so this one here, is responsible for brain function, fat, liver, and testicular function. It is involved with bone resorption, brain function, breast proliferation. The other pathway, this one here, remember this was that one, this one here, 5-alpha reductase, is responsible for the skin, prostate, and liver, which includes hair, body hair, facial hair, prostate growth, and acne. So here's your question to begin with. So if testosterone grows hair, as you know, it stimulates hair growth. Why can't we put it on your head to stimulate hair growth on the head? Okay, so think about that. If you have the answer, great. And so we always go by the Bing Crosby School of Medicine. Accentuate the positive and eliminate the negative. And if you don't know the next two lines in the course, it's latch on to the affirmative and don't mess around with Mr. In Between. Okay, so testosterone in adequate amounts is great. Too much is no good. Too little is no good. So testosterone does all of these things. So strength, energy, sense of well-being, libido, mood, awareness. It increases good cholesterol, HDL, decreases LDL, bad cholesterol, stimulates bone marrow production, stimulates the kidneys to produce erythropoietin, which increases red blood cell count. It increases bone density, increases muscle strength. So, who wouldn't want that, right? Especially those of us we're a little bit more mature now. Early life influences in the first 2 trimesters of pregnancy is when the brain develops and the development of male sexual characteristics. There's a pretty strong theory, there's pretty strong evidence that high levels of testosterone in utero is a causative factor for autistic children. The male to female ratio is about 5-to-1, and a lot of these kids are born with and have very high testosterone levels for their age group. So I got introduced to it as I was had a friend who had a 10-year-old who was autistic. We were actually out here in South Lake a couple of years ago in the summertime. Kid was about 10 years old, and we were walking somewhere, and we walked, unfortunately, right in front of a band that just was getting ready to warm up, an outdoor band, and they had a floor-to-ceiling mic or amp, and the guitar player struck a note right as we walked in front of it, and the kid went just bananas. You know, they're very hypersensitive and all, and the mother was, you know, calming him down, and I was just watching him, and I said, this kid looks like he's got road rage. And then, you know, it was summertime, he had shorts on, and he's 10 years old, and he had a lot of hair on his legs. So later on, when I asked her, I said, does he have any hair down there? And she says, yeah, he's always pulling on himself, and it's really embarrassing. You know, and so we did. The kid was 10 years old. He had a total testosterone level of 674. 10 years old. So, so there's some pretty good evidence for that. And one of the things that we do with these kids is we don't use puberty blockers. There are a lot of herbal remedies that you can use to sort of decrease testosterone levels if they're high, that are not, you know, they're not going to, you know, change the kid's orientation and you know, delay his development. So we'll go through a few of those later. In the first 6 months of life, there's a little bit of mini puberty, and a lot of, especially first-time parents, notice that the genitalia become pretty prominent. And then at puberty, ages 11, 12, 13, whenever that happens, the testosterone levels will increase by 10 to 20%. That's where you get testicular and prostate development, the growth spurt, the head hair, body hair changes, the facial hair. You get erythropoiesis, and male hemoglobins rise by about 15 to 20% from pre-puberty through puberty. Another little fun fact, if you want to just for fun, is that the second finger, the index finger and the ring finger should be in proportion. And in men with the higher the testosterone level, the longer the second finger is to the fourth. And so for females, the ring fingers, the fingers should be about even. And when they're higher, that's a more feminine hormone in utero, in the system. So, okay. So for men, the ratio of 2 to 4 is lower, than in females it's higher. So I think I got that backwards for you. This is females, this is male. So if you look at your fingers, your ring finger should be longer than your index finger for the guys. If it's not, then you have more feminine characteristics. Okay, so you can extrapolate that. So you can look at your fingers and say, you know, those that have gender dysphoria, well, is that true or not? They would take a look at the lengths of their fingers. I don't know if that's right or not, but it's just kind of a little bit of a fun fact. So with adequate testosterone levels, androgen levels are inversely correlated to social and language skills, and these are landmarks that should be developed. So the baby should be able to make eye contact at 12 months. They should be getting some vocabulary between 18 and 24 months, social skills at 48 months, and empathy at between 6 and 9 years old. So, and like I said, high androgen levels are associated with autistic traits, genes that are involved in steroidogenesis, and higher rates of androgen-related conditions, so like polycystic ovaries in females. So, okay, so on average, a 7-year-old child has a 256% increased level of testosterone versus the non-autistic boys. And the FSH levels are about 35% lower. So this is just sort of a schematic of if you have adequate testosterone, you have, again, memory, concentration, muscle mass, anti-inflammatory cytokine, interleukin 10 is much higher in greater number. So again, you told me you work with you know, hormone They'll come in and they'll say, yeah, my back doesn't hurt nearly as much, my neck doesn't hurt nearly as much. Skin turgor is much better, endurance, exercise endurance, oxygen uptake, and bone density is much better. And then again, so the things that you don't see, or you see much less of: fibromyalgia, arthritis, poor skin, poor sexual function, inflammatory cytokines are depressed in interleukin 6 and TNF alpha, poor muscle tone, hypertension, the bad cholesterol, anxiety, depression, mood swings, dementia, and Alzheimer's are all less with adequate testosterone levels.
I get this question all the time. Excuse me. Pardon me. People say, okay, you're lowering my cholesterol, we're now down in the 50s, the LDL, or lower. There is no bottom limit. What about my testosterone? Because of the connection with the testosterone. So,
yeah.
What are they, maybe you're going to talk about it here later in a little bit, and you're going to jump the gun, as far as that impacting on testosterone production?
Well, statins obviously will impact on testosterone production, and I think the number that's been studied is that when it gets below 140 total cholesterol, that's when you start seeing drops in testosterone not being able to form because you don't have the substrate.
So as far as the symptom or signs, do you start to see?
You're going to start seeing, if you pull out the side effect thing from the statins, and they list 9 million things that can go wrong. But if you know these sort of symptom clusters, you can start recognizing patterns. Okay, you start recognizing that these 20 symptoms are low testosterone and low estrogen. So you're gonna start seeing that. So I don't have a good answer about what to do about it, other than can you use some other means of lowering cholesterol?
You try nutrition, of course, that's the first thing, but that may be dropped to 10-15%.
Right.
Then you're dealing with people who've got vasculopathy.
Right.
So
yeah.
You're kind of pushing.
Yeah. I mean, I don't have a good answer for that. So, okay, this is just the same in what I showed you in that chart. Skeletal muscle correlates significantly with testosterone levels. Physiologic testosterone levels improve muscle strength by almost 50%. Lean body mass, body fat, and BMI are all directly related to testosterone. Again, adequate testosterone levels. Restoration to therapeutic levels. Remember, our goal is 700 to 900. That's where we find that guys feel pretty well, and 2 to 4% on the free testosterone. And I'll go over how to 2 to 4%. Yeah. If the free androgen index, I think I alluded to that earlier. If you get the sex hormone binding globulin, you can figure that out. For guys, 30 to 130 is normal, and about 50 to 120 would probably be about your optimal. So therapeutic levels will on average decrease weight by almost 5.5%, abdominal fat 2.5%, gluteal fat by 1%, and then BMI by 4.5%. Lipid reduction. So total cholesterol at the end of the 4th week, lipoprotein A, apolipoprotein A, HDL will go up, serum albumin will go down, and you'll get an improvement in the whole lipid profile. Higher total testosterone and sex hormone binding globulin are inversely related to carotid artery atherosclerosis. And when you have the patient go from the lowest quartile to the highest quartile, and they stay there for at least 6 months, we see a decrease in carotid intimal thickness with total testosterone in the adequate range at 52% and sex hormone binding globulin at 62%. So I think one lab tells us 10 to 57 for sex hormone binding globulin is again normal, but I'll go over that formula again on how to figure that out. The number itself doesn't really matter. It's what's our free androgen. That's what really counts. So low testosterone increases the risk of coronary artery disease via inflammatory mechanisms, particularly with interleukin 6, TNF alpha, and you'll have an increase in C-reactive protein. It's inversely related to testosterone levels are inversely related to the severity of the coronary artery disease. Cardiovascular events and metabolic disorders are more common in men with low testosterone levels. Testosterone therapy decreases the cardiovascular risk in men with androgen deficiency. And at physiologic levels, testosterone inhibits reactive oxidative stress. And at supraphysiologic levels, testosterone will decrease nitric oxide formation and increase oxidative stress. So again, Goldilocks, not too much, not too little, just right. So this is about heart attacks, strokes, and mortality. So right around Thanksgiving 2013, this big news came out of a VA in Boulder, Colorado, that testosterone causes heart attacks. It increased the rate of heart attacks, double the rate of heart attacks and strokes in the first 75 days of treatment. And it was big news. It was all over the New York Times, and it was on the news, and it was all over the place. And oh my God, everybody's hair was on fire. And those of us had been doing this for a while said, wait a minute, we don't see this. That doesn't seem quite right. In fact, we had last summer, we had a guy call us on a Monday, said he'd had an MI and he was in the ER over the weekend, and they had a stent put in. And I was like, okay, we had seen him just for a little while. It happens. The guy was 63 years old and had a heart attack, right? And I started to think about that, and I called my assistant in. I said, when was the last time we had anybody in our practice have a heart attack? And she said, that's the first one I can remember, and she'd been with me for 8 years. Right? So we don't see it. We don't see guys, with heart attacks. I mean, I'm sure they have them, but I mean, our incidence is way lower, and we're seeing mostly middle-aged guys. So our incidences are way lower, and you've been working with hormones for a while. I don't know if you find the same thing, or?
Yeah, I haven't seen it at all.
Yeah. Mm-hmm. I know, right? But I guess the cardiologist will tell you it's because they lowered their cholesterols. I don't know. Anyway, so there was twice the incidence of heart attacks, strokes, death within the first 75 days, and all events. Except there was a little problem with what they reported. So the light gray here are the patients without testosterone. The dark was the patients that were treated with testosterone. So as you can see, in all events, 21% of these patients had some sort of event in the group that was looked at by this vegan. 10% of the patients had some event that were testosterone treated. But the report was that there were twice as many heart attacks, strokes, and complications with the testosterone group than with the non-testosterone group. The exact opposite of what they showed. They reported that this was the testosterone group, and this was the untreated group, when it was the exact opposite. And you can see it here, right? Twice the amount of death rate, 3 times the amount of heart attacks, more than twice the amount of strokes without testosterone than with testosterone. Did anybody hear a retraction? No? Did you hear anything? And you've been around long enough, you probably remember this, right? So our good friend Abraham Morgenthau, sort of the guru of testosterone, he went to bat, and he set out and he showed them that they were totally wrong. So bone density, the testosterone can increase bone density by up to 1.8%, which is as good as the bisphosphonates without all the side effects and without their teeth falling out. This was just a little fun study. Did I show you this one before? With the Porsche and the Toyota Camry. So if it proves anything, it's that you can find grant money for anything. So this group of researchers, we'll just call them that, recruited 39 young men in their 20s measured their testosterone levels, let them drive a Porsche 911 for an hour, and then drew their testosterone levels again. Okay? And as you can see, the testosterone levels zoomed. Then he came come back the next day and had him drive a beat up old Toyota Camry station wagon. And the response wasn't quite the same. So there was so again, behavioral issues. You know, the guys who drove the Porsche had significantly and substantial increases in testosterone levels. There was another slide to this, a second one that I left out, but maybe I can mention it since there's only the few of us here. And the second slide was that the same group went to divided it by political orientation. And so they divided you into strongly Democrat, weakly Democrat, strongly Republican, weakly Republican. And the end result here was that if you were strongly Democrat or or weakly Republican, there was no change. But when we got your testosterone levels up, 45% of the weakly Democratic participants switched to Republican. So again, infer what you will. So I talked about this. Testosterone is not stored in the testes. It's 2% bioavailable, about 54% weakly bound to albumin, 44% weakly bound to sex hormone binding globulin. If you take it all into consideration, it's considered bioavailable testosterone. I think you can ask, a couple of the labs will do that for you. They'll do bioavailable. If not, you can get these numbers. If you get the sex hormone binding globulin and albumin, you can just go online, put in bioavailable testosterone, and there'll be formulas where you can put the number in. I do it without the albumin. I find it works quite well, and I can do it in seconds, and I don't have to be in front of a computer. So sex hormone binding globulin is a protein made in the liver. Mostly it transports androgens and estradiol. And so it's the transport mechanism. When the hormones are bound to protein, they're inert, and they're not functioning. So we need to know what the ERT portion is. So it signals a heart, brain, and an adipose tissue, and it binds more tightly to androgens than to estrogens. It increases as we mature, and at this pretty much the same rate as estrogen and testosterone will decrease as we mature. So normal. These are the normal values: 10 to 57 for males, and 18 to 144 for females. So that it's kind of useless. The number doesn't really matter. What you need to do is, and I'll show you how to figure out the free androgen index in a minute. And so we want to know if they're in the acceptable free androgen range or not. That's what you really need to know. So high sex hormone binding globulins are present with high androgens, prostate cancer, osteoporosis, increasing age, hyperthyroidism. Low sex hormone binding globulin is present with high testosterone, metabolic syndrome, high insulin, obesity, C-reactive protein, triglycerides, and LDL. So, there's inflammation on both sides, and it's really hard, sometimes to infer if you have a high or low sex hormone binding globulin, just the number itself. So we really need to know, put you through the paces. It'll increase with estrogens, birth control pills, progesterone, thyroid hormone. That was from Philadelphia. C. roaches of the liver. You know what that is? That was from Metropolitan Hospital. Liver cirrhosis, right? You say, hey, doctor, I got C. roaches of the liver, right? Probably should change that, right? They're recording this. I probably should change that. C. roaches, right? Right? So anorexia, starvation. Intermittent fasting, you're going to get a higher sex hormone binding globulin. Growth hormone deficiency, androgen insensitivity, St. John's wort will raise sex hormone binding globulin. Usually we want to lower it. We don't really usually, most of the time, want to raise it. So to lower it, again, testosterone, DHEA, growth hormone, hypothyroidism, too much cortisol will lower sex hormone binding globulin. This is our go-to here. Boron, we start at 3 milligrams and go up to 9. Usually you don't need to do more than 3. On average, it'll decrease the sex hormone binding globulin by about 50%, and only takes about 4 to 6 weeks. It's really pretty effective. Nandrolone I've seen used for it also, if you want to use the synthetic, the testosterone. Vitamin C, stinging nettle, we use that with quercetin for allergies, and that also will lower sex hormone binding globulin.
Vitamin C.
What's that?
Level of vitamin C intake.
Yeah.
Is there like 500,000?
1,000, yeah. So lifestyle changes, coffee anyone? We'll raise it. Oral contraceptives, lose some weight. Also, we'll raise it. Green tea extract, whole foods, flaxseed oil. What will also raise, if you raise prolactin levels, and that'll happen with SSRIs, tricyclics, MAO inhibitors, antipsychotics, the benzos will do that. Morphine, these all raise prolactin level. Other drugs that will raise sex hormone binding globulin. So you got your relaxofen, your SARMs, tamoxifen, spironolactone, oral contraceptives, metformin, and danazol will all raise it. I don't usually need to raise it. That's not something that's a useful thing. So for testing, the state of Nevada likes serum testing. They don't like urine or saliva. And so we look at total testosterone. Most of the labs will give you a calculation of a free. I don't really find them all that useful. The bioavailable, like I said, you need the sex hormone binding globulin and albumin. And then I'd go online and just type in that. You'll find a calculation there. Or I'll show you how to do the free androgen index. We talked about it earlier. With chronic hypogonadism, we get a DEXA scan. If the testosterone levels are less than 150 total and they're they have other types of symptoms, you may want to look for pituitary adenoma, chromosome studies. If the pubertal males with Klinefelter syndrome, you'll find low total testosterone but high FSH and LH, and that'll be a Klinefelter syndrome. Low FSH, high testosterone in a prepubescent male that's sort of the pattern, your pattern for autism. Okay, so here are some of the issues that we deal with testosterone: acne, sleep apnea, gynecomastia. We already talked about cardiovascular issues, erythrocytosis, prostate and prostate cancer, testicular atrophy, and infertility. So, so the two that we're going to sort of concentrate on is prostate cancer and polycythemia vera. It's a knee-jerk reaction. You see a red blood cell count of 55, or hematocrit of 55. Come on in. The water's warm. We see a red blood cell count of 55, and oh my God, you're going to have a heart attack. You're going to have a blood clot. You're going to have a stroke. You got to get off of that stuff, and that's not true. And we'll show you that in a minute. So we're going to start about prostate cancer, and I'm going to give you the bottom line is high levels of testosterone doesn't increase risk of prostate cancer. It doesn't increase the incidence of prostate cancer. It doesn't, if they have prostate cancer, it doesn't influence the progression. It does not cause an exacerbation of it, and it does not cause a rapid progression and death. It's all a myth. That perpetuates even today. If any of you have students, they'll come in and I'll ask them what they're taught, and they're still taught testosterone causes prostate cancer. And so, that came out of that study from Huggins and I forget who the other one, Huggins and somebody, another H. It was in 1941. They looked at 3 men that had prostate cancer. They did an orchiectomy on one they gave testosterone to, and one they left alone. The one they left alone, and the one that they that they gave testosterone to, the prostate cancer got a little bit worse. The one that had the orchiectomy, the prostate cancer receded. So their conclusion was that there was a 67% increase in testosterone in prostate cancer incidence and risk with using testosterone. 3 patients. And that was gospel till the 90s, that Morgenthaler came along and sort of blew that out of the water. The FDA warning became more stern in 2014 after that vegan study. Again, knee-jerk reactions without, saying, giving it any thought. And really, if you think about it, it's pretty easy to just, blow that whole scenario out of the water. Who gets prostate cancer, young guys or old guys? Old guys. Who has high testosterone, young guys or old guys? So how come the young guys don't get the prostate cancer? Right? I mean, nonsense. Okay. And so this is where here it is, Huggins and Hodges. I couldn't think of the other name. This was the study, 1941. 3 patients. They treated them for 14 days. The one guy had no change. One guy it got worse. One guy it stayed. One guy got better. So there it was, 67% increase incidence of prostate cancer. So, so since that time, since the mid-90s, there's multiple studies that show no prostate cancer progression with testosterone administration. Some of them are subject to get improvement in bone pain. They do get, all of the good things with testosterone: strength, energy, sense of well-being. They have interest in life again. They come back to earth. No reduced risk of prostate cancer with low testosterone. No relationship between prostate cancer risk and serum testosterone levels. This testosterone increased the risk of prostate cancer. This was a study. This was one of Morgenthaler's. 3,800 men with prostate cancer, 6,400 without. There was no relationship between the androgens and prostate cancer, and there was no difference with the patients that had the highest 20% and the lowest 20% quartile of testosterone with prostate cancer. There was no change. Does it increase the risk of prostate cancer? This has 10,000 men that were treated, 28,000 untreated, follow-up more than 5 years. The control patients that were untreated, slightly more increased incidence of prostate cancer than those that were treated. There was actually a greater reduction in prostate cancer risk with the longer the testosterone was administered. So how do you explain this? And how do we explain this versus the conventional wisdom that the higher the testosterone levels are, the more you get a prostate cancer risk? And the answer is it's that the prostate can absorb so much testosterone, and then that's it, no more. And so this, at high concentrations, the prostate growth is insensitive to any more androgen. And when the androgen receptors are filled up, that's it, it's not gonna grow anymore. So testosterone, if the testosterone levels are very low and we administer testosterone, you will get some small increase in prostate growth, but up to a certain point and then no more. And the point is PSA of 2.5. So anything over 2.5 is not attributable to the testosterone itself. Okay? So castration causes prostate cancer to regress. Higher testosterone levels fails to cause prostate cancer to grow, and it's because it's a saturated. The receptors become saturated. There's that 2.5%. Yep.
So for your testosterone replacement patients, do you follow PSA at all?
Yeah. I only do it because, it's conventional. I do it because it's done. Okay. All right. And, if it goes up, they get some of them will get a little bit antsy, but, we show them these studies and all, and most of the patients are pretty good. The only ones who don't want to look at it are doctors. They could care less, right? So The lower the testosterone levels, the lower the PSA. Testosterone therapy normalizes PSA, and to correctly interpret it, you have to know what it was above and below the saturation model. Okay, so the saturation point is 2.5%. 2.5. That's the magic number. Okay, this testosterone therapy increased the risk of prostate cancer after radical prostatectomy, and the bottom line is that after radical prostatectomy, there was a reduced recurrence and delayed time to recurrence. The testosterone recurrence rate was 7% and the untreated rate was 12%. So, did almost twice as well with it than without it. If you don't like this one, here's another one. These were guys with Gleason score of 8 to 10, follow-up of 27 months, and 4 times as many men without testosterone had recurrence than those that had adequate testosterone. And then so the conclusion is testosterone therapy in men with untreated prostate cancer was not associated with prostate cancer progression. About active surveillance, i.e., we don't do anything. So testosterone therapy here, a Gleason score of 6 in 22 of them, 7 in 6 of them, compared with 96 men on active surveillance with no testosterone therapy. Basically, the groups were pretty much the same. Mean PSA did not change with testosterone therapy, and the prostate volume was unchanged. And every one of those guys had at least 2 biopsies. So the bottom line here is for radical prostatectomy, X-ray therapy, active surveillance, the recurrence rate in the radical prostatectomy and active surveillance, do nothing group was about the same. X-ray therapy seemed to do the best, but the 5-year recurrence rates were all the same. So in other words, it's much ado about nothing. Okay, there's this flare that happens. So we give them Lupron or one of the other hormone-releasing agonists, and you get within the first 3 weeks, you get an increase in testosterone of up to 300%. You get this testosterone flare, and it was initially feared that this would cause a rapid progression of the prostate cancer cells, and this proved to be not true. Also, no evidence for increased risks associated with testosterone flare. Here's 5 more studies showing the exact same thing. No disease flare. Testosterone flare does occur with or without anti-androgens, usually with the anti-androgens. PSA flare was not demonstrated in random controlled trials to date. The disease flare has not been demonstrated, and historical concern about that flare, again, was pretty much ado about nothing. How about metastatic cancer causes rapid progression and death? So 22 men with total testosterone, 13 men with metastasis, average age of 70, duration of 12 months study on the testosterone group, 20 months on the recurrence group, and we did get some increase in PSA levels, but all the patients reported symptom relief, with especially vigor and well-being. The overall mortality rate was 13% in the prostate in the untreated testosterone group, and 4.5% in the testosterone treated group. So again, you had 3 times the better rate of living with testosterone than without. 7 of the 10 men follow-up imaging showed no progression at all. Some of them developed some bone pain. 5 men died during this study. 3 of them during taking testosterone. 2 of them 2 years later. One of the 3 deaths that was determined to be testosterone specific. So out of all of them, 1 death out of all of them versus the much larger number. So this is Teddy, kind of typical. He's 95 years old. His wife had passed away 8 years earlier. He had one interest in life, Texas Hold'em. That was it. He was interested in 4 women, the queens of spades, clubs, hearts, and diamonds. That's all he cared about. He'd call at his office. He'd go into the office. We'd ask him how he did today. And he says, well, they took their allowance, but they fed me. So he'd spend $200, $300 a night playing Texas Hold'em to get a free $12 hamburger. But that was his life. He had a Gleason score of 10. He had metastatic prostate cancer cells in his right lung, of all things, and in the lumbar spine, a PSA of 46, and a testosterone of 46. He was treated with Lupron. He didn't want to get out of bed. He was apathetic. He says, basically he said if he couldn't go to the casino, he didn't want to live. You know, he's going to just pull the covers over his head. So after a while, well, we talked to the family. We said, what can we do? We showed him some of these statistics. We said, give him a little bit of testosterone. We gave him, I think, 20 milligrams to start. So 1/10 of a cc, IM weekly. And so what do you think? So we did that, and then I called Mark Rosenberg. He's the integrative oncologist. He's the Mr. Big at A4M. And he's been doing this a long time. And so we came up with this protocol. We gave him 400 milligrams every 2 weeks, which in retrospect was probably too long. We should have done it every 10 days. Remember, the testosterone cypionate has a half-life of 12 days. So we're almost like starting over again every 2 weeks. And then in between, we gave him this anti-androgen injection. There was a 50% decline in PSA within 8 weeks, and he went and had another. He had a MRI and showed a 50% decrease in the tumor burden. So this was before we started. This was as good as it got for him. 8 weeks later, he's in a restaurant. These are his great grandkids. He's sitting up. He's eating. He's looking pretty good. During the lockdown, he passed away. He ate that, and he pulled the sheet over his head when he couldn't go to the casino, and he said, they'll never open again. He says it was worse than Pearl Harbor. So here he was, pre-testosterone. Here he is post-testosterone. So, there's a bit of an ethical dilemma there. But family, they let us know that, he got to do what he wanted to do. He got to be with his family. He got to do things. Did he die sooner than he should have? Well, he was 95 to begin with. So he was much better off here than he was here. So again, here's the conclusion. High levels of testosterone do not increase prostate cancer risk. They don't increase the risk of prostate cancer, the spread of prostate cancer. They don't exacerbate metastatic cancer, and it does not. The testosterone therapy in metastatic cancer does not cause a rapid progression and death. So what are you going to do? What are we going to do with all of this? Right? So guys got prostate cancer. If they had a radical prostatectomy, if the PSA is low is less than 1.0. And really 0.1 is kind of what the urologists look for. When the PSA is undetectable, 3 months post-op, we can begin, again, low-dose testosterone. So I usually do use half doses. If they had X-ray therapy, when the prostate is low, PSA is low, at 3 months post-op, active surveillance, you can really begin it at any time. The PSA will probably rise some, but don't get too excited about it. And if there's a recurrence, you got to play it by ear. Okay, got it? Okay. This is just and oh, by the way, I got this from Terry Hertog for a benign prostatic hypertrophy. This was a suppository compound, 100 to 150 milligrams of progesterone and 300 milligrams of ichthiol in a suppository will reduce prostate volume within 6 months by 30 to 60%. That's just an oh, by the way. So the next big one is erythrocytosis. Red blood cell count. We get.
Last slide there. So were they symptomatic?
Yeah. Mm-hmm. Yeah. Mm-hmm. So erythrocytosis. Again, what were we taught? Testosterone, blood clots, you're going to die, right? Wrong. High levels of testosterone does not increase the risk of blood tumors, cardiovascular disease, strokes, or venous thrombosis. It just does not. I can get you the references. I got them all. So, testosterone induces erythropoiesis, definitely. Hemoglobins rise through puberty, 15 to 20%. Hypogonadal men have lower hematocrits versus age-matched controls. Testosterone therapy restores hemoglobins to quote-unquote normal, and testosterone therapy increases by an average of 7% within the first 3 months of beginning testosterone therapy and 10% within the first 6 months. You'll get an increase in testosterone, in hemoglobin and hematocrit more readily with the injectable testosterones versus the transdermal. Testosterone-induced erythrocytosis is defined as a hemoglobin of greater than 18.5 and hematocrit greater than 52. The transdermal incidence is 43% with the IM injections, 15% with the transdermal injections, and the transdermal incidence is dose-related. So the higher the dose, the more likely you're going to get an increase in red blood cell count. EPO levels are high, so erythropoietin levels are high, and an elevated hemoglobin and hematocrit will naturally suppress erythropoietin levels, but they will remain 6 months after testosterone therapy elevated by about 30%. Testosterone induces erythrocytosis, but does not change the white cells or platelets or clotting factors. So basically all you need is a CBC. The red cells are high and the white cells and the platelets are normal. That's all you really need to know. Now, if you deal with the VA, they get all excited about it and they are sending every guy with a hematocrit of 51 over to the hematologist for a bone marrow, and they told him they had polycythemia vera. Okay? Yeah. Just ridiculous. So there's a iron peptide, a regulatory peptide called hepcidin, and hepcidin becomes suppressed with testosterone therapy, which increases red blood cell production. It also happens with interleukin 6, so anything that increases interleukin 6 can suppress this hepcidin, and we'll get an increase in red blood cells. You'll get a suppression of ferritin levels. We do ferritin levels on all our thyroid patients, so we usually don't get them right off. That's not in our initial batch of blood tests. Maybe it should be, I don't know. But ferritin levels are suppressed here also. You get an increased iron utilization. Hepcidin is also suppressed by high vitamin D, sorry. Okay, so remedies for this. If you increase interleukin 6, you increase hepcidin, and you'll get a partial remedy for erythrocytosis. So go out and tell them to eat bad stuff and do bad things, and the red blood cell count will go down. Exercise, 2 cups of coffee a day. High fat, high sugar diet, that'll work. Don't sleep, drink yourself silly. Elevated T4, melatonin will sort of temper the erythrocytosis. Normalize deficiencies in vitamin D, zinc, magnesium, calcium, vitamin C. Supplements creatine, which builds muscle, 5-HTP, aloe, astragalus, reishi, and drugs, fluoxetine and venlafaxine. And you've heard this before, how I feel about venlafaxine. My students, if they write for that, they fail. So, I mean, that's probably one of the worst drugs there are. So a little bit about polycythemia vera. So polycythemia vera is classified as a myeloproliferative neoplasm. It's a blood disease. It's an increase of red cells, white cells, and platelets, and an increase in alkaline phosphatase. There are the numbers that you need. So you need platelets greater than 400,000, white cells greater than 12,000, and you need all of them. Polycythemia vera is on the rare disease list. It's not something we see every day, and it certainly isn't what we see when we give patients testosterone. Polycythemia vera leads to increased risk of blood clots, heart attacks, strokes, embolism, anything that has to do with blood clotting. 97% of these patients are positive for the JAK2 or the TE2 genes, and their erythropoietin levels are low. Remember, testosterone, the erythropoietin levels are high. Symptoms are fatigue, vertigo, facial redness, blurred vision, pruritus or itching after a hot shower, increased mast cells, they get this mast cell activation syndrome, splenomegaly, gout, and gallstones, and then you get blood clots in the head, in the heart, in the veins, and in the liver. Treatment is for phlebotomy. They can't donate blood though. They can use it for autologous interventions. Hydroxyurea is a medication that will suppress symptoms. Yeah, these biologics, JAK, I can never pronounce them. JA2 inhibitors relieves the pruritus. Antihistamines, hydroxyzine, aspirin. There is a burnout phase where then the patients need transfusions. There's an acupuncture point on the underside of the helix of the ear that works nicely. We put a little semi-permanent needle in there. It'll last about a week or so, and that'll for itching. That works quite nicely. And so here's the bottom line here. Polycythemia vera is a bone marrow tumor. Erythrocytosis from testosterone is not. You'll get an increase in red cells, white cells, platelets, alkaline phosphatase with polycythemia vera. Erythropoietin levels are low, and there's gene mutations that you don't see with testosterone. Testosterone, you got high erythropoietin levels, and risk of high blood pressure is a risk if the levels get too high. But again, it's pretty rare, and fluid overload. But again, that's rare. I don't see it. All you need is a CBC. If the platelets are normal and the white cells are normal and the red cells are, hematocrit's 53, you're dealing with, it's just testosterone. That's all.
Looking at this altitude, do you see many patients who come in higher than you saw maybe back then?
Well, it's a little high. We live in Reno. We're at 4,500 feet on the valley floor, so it's going to be higher to begin with. So, and quite frankly, I don't get too excited. I mean, I've got guys with hematocrits of 60, and I don't get excited over it. I explain it to them. I tell them, if you do get a phlebotomy, sometimes they say that they feel lighter. So if they want to feel light, that's fine. Okay, and we do them in the office, real quick. They make a big deal out of it. They got a whole sheet you got to fill out. You got to send them to a plasma center or a drawing center. Right? A whole sheet. I do it in the office. It takes 10 minutes. I charge them 70. I think we charge them $50 for it, and finished business. No, it's no big deal. Yeah. Yeah, it takes 10 minutes. It's no big deal. The worst of it is that those kits for the phlebotomy, the needle's really big.
Like 10 gauge.
Yeah. I'm sorry when this kind of got these numbers. The columns got messed up. But so general population stroke is 5.3 out of 1,000, and polycythemia vera 14.3, so 3 times as much. A little bit higher with testosterone, so just slightly, but not much. Heart attacks, it's 34 per 1,000 for the general population, 30 with that should be over here, and 90 for polycythemia vera. So again, blood clots, there's 3 times the incidence of blood clots with pretty much everything with polycythemia vera. The testosterone levels are actually, for the most part, better than if they had nothing at all. And so it's 10 here. This is 8, by the way. That's what that is. I'm sorry, I downloaded this to put it on the jump drive, and the columns get messed up. There's the references for that. Cardiovascular risks are actually a little bit better with testosterone than without. It's not associated with increased risk of incidence of composite cardiovascular events. Overall mortality, patients that were testosterone treated, 8.4%. In this study, without testosterone, 19%. So almost 3 times as much. Decreased survival rate, without testosterone is at 2.3 times the level. Low testosterone levels showed a 35% increase in mortality, and acute events do not correlate with elevated erythropoietin levels. So again, our conclusions here, high testosterone levels does not increase blood tumors, the risk of blood tumors, cardiovascular disease, strokes, or blood clots. A couple of other things you'll see. Yep.
I know, I'm sorry, I'm going to keep both places going, but share my personal experience. Ever since I'm on the testosterone, a surprise, somebody accidentally drew my testosterone before shoulder surgery, and I also almost didn't do the shoulder surgery because I had a hypertensive crisis. I didn't know I was hypertensive. And so after shoulder surgery, I started doing testosterone. I tried a few different agents, and I'll tell you another story about getting off of atenolol at some point. But between testosterone, beetroot powder, and just taking care of myself, all those things kind of came down. So I mean, I absolutely agree with that. I mean, everything, the mortality actually goes down, I would say. I mean, all the risk factors we worry about metabolic syndrome, I'm actually.
And unless I'm mistaken, and your coloring of your hair looks darker too, or is that Miss Claro?
Well, that's the guy that's on here.
It looks a little darker to me.
It's much better.
Yeah. Or maybe it's the singing. I don't. You know.
Even more white.
You ever have you seen Bruce sing? I mean,
That was my biggest fan last night.
you know, he gets into it. You know how much blood flow he's got going to the scalp when he hits those high notes.
Rock and roll. I got one video.
Oh, okay. Yeah, I have him somewhere. Well,
Was I singing when you danced with Tammy, or was it the movie where she sang? I can't remember. Okay, so Tammy was singing when she grabbed you up.
Right, right. She was singing out, but dancing.
You missed a good time, though.
Okay. So we'll go someplace tonight, right? All right. So gynecomastia, the man boobs, is an issue, and it's an imbalance between estrogens and androgens. And it will, if you're unregulated, it'll start showing up within 4 to 8 months of testosterone treatment. The enzyme responsible for converting testosterone to estrogen or estradiol is aromatase. It's a CYP19A1 member of the cytochrome 450 pathway. It converts androstenedione to estrone and testosterone to estradiol, and it will induce inflammatory cytokines, interleukin 6, interleukin 1, and interleukin 1 beta. Increased aromatase activity is seen with inflammation, mold, biotoxins, low testosterone, high LH results in high estradiol, high insulin levels, traumatic brain injury, 5-alpha reductase inhibitors, prolactin, and glyphosate will increase aromatase activity. This is just pretty much the same thing, just sort of in a little bit of a chart form. You get the aromatase triple whammy, as I call it. So estrogen stimulation is ineffective without anterior pituitary hormones. So you won't get the man boobs without adequate growth hormone. So the guys taking growth hormone and testosterone, they're more at risk for developing gynecomastia than those that don't. You need adequate IGF-1 mediators, otherwise the breast tissue does not develop. Aromatase activity increases with increased body fat and hypogonadism. It increases with increased sex hormone binding globulin. Sex hormone binding globulin binds to estrogen less effectively than testosterone, and it gives us a relatively low testosterone level. Low testosterone equals high LH, which gives us a high relative estradiol level. And hyperthyroid conditions does the same thing. So predispositions is overweight, alcohol, caffeine, tight underwear, which stagnates blood in the pelvis and increases body temperature. Other causes are anabolic steroids, estrogenic grooming products and plants, lavender oil, tea tree oil, medications, particularly finasteride and spironolactone. Liver failure produces decreased production of sex hormone binding globulin, estrogen producing tumors, and testosterone deficiency. Treatment, so you got to get them off the coffee, get them off the booze. get their weight under control. If they have erectile dysfunction, we're going to use an Arimidex, an estrogen blocker, in a low dose, quarter milligram, half milligram, up to 3 times a week. If they don't have erectile dysfunction, you can give them progesterone, 100 milligrams at bedtime, and we always add in about 100 milligrams of DIM, diindolmethanol, methane. 100 milligrams is usually enough. If they're on testosterone, you can lower the dose by 25%. You can have a DHT cream compounded to put on the breast tissue. We don't do that anymore. We actually take progesterone cream. You can get that over the counter. We have it in the office, but they can go to a makeup store, they can go to CVS and buy a progesterone cream over the counter. 2% is 20 milligrams, 5% is 50 milligrams. I've seen it online as high as 7.5%, without a prescription, and just have them rub it on the breast tissue, and usually it'll take about 2 months. It'll go away. You can add sulforaphane, so broccoli extracts, which activates NRF2, and would also sort of disrupt that pathway. There's the references for all of that. Aromatase inhibitors, so the prescription ones, anastrozole. We don't use it 7 times a week. I usually would not go more than 4. And then, as you've heard me say, there's the big controversy of letting the estrogen ride. So that's a whole nother story. Spironolactone, 25 to 100 milligrams. We usually start at 25, or metformin at 500. Also can act as aromatase inhibitors. This is the case for not blocking estrogen. Like I told you, there's one of the lecturers at AMMG actually actively takes. Last time we were there, he said 7 milligrams of estradiol. The time before that was 8 milligrams of estradiol. I mean, I think that's kind of crazy, but you be you, I guess. They really harped on the fact that when you block estrogen, it will induce osteoporosis. I think you have to block estrogen for a long time for that to happen. We know not to get the estrogen levels down to 0. We didn't know that 20 years ago, but we know that now. You don't want estrogens down to 0. When it gets over 40, I see, again, erectile dysfunction. I see emotional, labilities. We see guys with increased incidence of heart attacks and strokes. So I don't really get it. I'm going to show you one of the studies that they quoted, and the headline says estradiol, blocking estradiol causes osteoporosis. But if you look at the data that they present, remember, just sort of like the vegan data, the devil's in the details. So I'm going to show you that. Aromatase inhibitor causes breast swelling. So aromatase inhibitors, you're going to block estrogen. So you're going to get low estrogen symptoms and high progesterone symptoms. So abdominal bloating, mood changes, hot flashes, night sweats, and that's sometimes a problem with the gonadotropin releasing hormone antagonists that happens in guys. They'll come in with low estrogen symptoms. Estrogen deficiency, you'll end up with vascular insufficiencies, cognitive decline, decreased libido, depression, mood swings, and fatigue. So osteoporosis, low serum estradiol levels are associated with low bone density and increased risks of hip fractures. And this is one of the things that, again, at AMMG, they kind of harp on. Bone turnover and bone loss are accelerated at 40 p-moles in men and women. And the guys with low testosterone and low estradiol levels are the greatest risk for hip fracture. The 1-year mortality for a male with over age 65 with hip fracture is 37% greater than in men versus women. So you don't want these guys breaking their hips. But there's ways to do it without flooding them with estrogen also. So cardiovascular risk is another reason. We know women have a lower incidence of cardiovascular disease due to estrogen protection, at least through the first 10 years post-menopause. And a low dose of estradiol has been proposed as a reasonable supplementation in hypogonadal men. It will help lower blood pressure, and it's beneficial with circulation. both in cardiac and cerebral circulation. So one of the things that we learned with totally blocking out estradiol, when we got the estrogens down to zero, is the guys ended up with memory issues and balance issues, things like that. I mean, that's totally, the case. But I think you need to find a balance in between. Not too much, again, not too much, not too little. 15 to 25 is a reasonable sort of range for estradiol in guys that are on testosterone. I usually let it ride up to when it gets over 30, we'll use some of the herbal remedies or over-the-counter like Chrysin or saw palmetto. When it gets over 40, we'll want to bring it down to at least under the 30s. Okay, physiological estradiol levels reduce blood clotting factors and improve cholesterol. So, we always, I don't know if it's, since I'm not around anymore, the academic world, but there's no medications or drugs that will raise HDL, right? Is that still the case? But if you raise estradiol levels, that will raise HDL. So again, if you let the estradiol levels rise a little bit, it will raise HDL and lower LDL. So cognitive function, again, estrogen drives blood flow to the brain. You need some estrogen in the brain. Estrogen deficiencies accounts for increases in body fat and testosterone deficiencies. Higher estradiol levels have longer telomere lengths. So, telomeres are those little end caps at the ends of the chromosomes that can determine longevity. And the estrogen deprivation strongly correlates with obesity. So these were the studies that they actually pulled out and used to say that you don't want to block estrogen, just let it run. And like I said, there's this Dr. Camarella, I think his name is. I don't remember exactly what his name is. He's the guy who takes 7 milligrams of estradiol a day. He treats his patients. He does only pellets. So when you do pellets, the serum levels they don't really correlate with the tissue levels. But he wants serum levels of testosterone of 2,000 and estradiol levels of 150 to 175. I'm just telling you what's going on here. There was a big fight over this, but so anyway, this is one of the studies that they showed with sexual dysfunction with estrogen, and if you look at it, the controls stay the same. The estradiol levels, as the estradiol levels went up, so didn't block estrogen, we went from delayed ejaculation to erectile dysfunction. So, most guys probably wouldn't object to that, especially as you get older, but over here, not so good. So again, when we get adequate estrogen levels, we're okay. When the estrogen levels get too high, we end up with issues. Here's the osteoporosis study that they cited. And so, yes, if you have low levels of estradiol, you're going to have a higher incidence of hip fractures. But as you get up into the levels that so we sort of recommended, remember I said 15 to 25, we're okay up to 40. The incidence of hip fractures goes way down, and anything over 35, it's actually it's a little bit more, but really it's pretty much the same. So the point is that when the estrogen levels are quite low, yes, there's an increased incidence of hip fractures and osteoporosis. Once you get over, here it's 18. Once you get over 15, you're really not affecting it one way or the other. And as you can see, you're going to have sexual dysfunction and all the other things that we look at with high estrogen levels. Higher estrogen levels in guys, you're going to get those also. This is another schematic of what estrogen does. So estrogen in guys, here's it does afford some cardiovascular protection. It does protect against the respiratory illnesses in the mid-range. This delivers the primary site of estrogen metabolism. It maintains phosphorus-calcium balance. It maintains skin turgor. And so, again, if you go to you do any nursing home work? Yeah, well, we did. Remember, you'd go, your patient's in the lunchroom, and there's, 30 guys and 40 ladies sitting in there, eating, and, some of them are all slumped over and they're all wrinkled up and they have osteoporosis, and then some of them are sitting up and they're, right? And then you can tell the ones that are sitting up and they had the smooth skin and all, those are the ones that had the hormones. The ones that are slumped over, they had nothing. I mean, it's pretty obvious. GI protects GI vasculature, bladder issues, intestinal issues, and genitalia. So again, some is good, too much is no good, too little is no good. There's the references for those. Remedies to bring the estradiol levels down without blocking it too much. Again, titrate your vitamin D to 50 to 80. Strontium, 1 to 2 grams a day will bring it up. Iproflavone, 600 milligrams with calcium. DHEA, testosterone, progesterone, estrogen. These are the ones we kind of go to now. Resveratrol, 250 milligrams twice a day. I do have to make a confession there. I write for a company I write articles for a company that produces resveratrol. I don't write about resveratrol itself or their product, so I should let you know that, okay? But 250 milligrams twice a day. Chaseberry usually comes in a combination with black cohosh. And the deal here is you need to look at the labels. You need an adequate amount of these supplements, because a lot of times they'll have 30 milligrams or 50 milligrams, and it didn't work because it's not enough. Spearmint tea works like a charm, and you need 100 milligrams of spearmint, and so we did a little bit of analysis, and I know it's CME, but can I mention the name? It's a tea company. It's not right? So Lipton tea bags. 2 tea bags, one tea bag is 70 milligrams of spearmint. 2 tea bags in 1 cup of water, 5 days a week, will decrease your testosterone levels, your estrogen levels by about 20% in about 40 days. It works quite well, about 2 months. The problem is it gets kind of old. The patients don't like drinking the tea all the time. You can use peppermint. It's not quite as effective, but you can turn with that. But that's an easy one to do. It works like a charm. If they do it, it's really predictable. Deglycerinated licorice, which we use as a substitute for PPIs, it works very nicely for GERD and hiatal hernias and esophageal reflux. 150 milligrams a day. It comes as a chewable. Also can act as a mild aromatase inhibitor and then omega-3 fatty acids. And again, you need enough, at least 2 grams a day, and you can go up to 4. Other aromatase inhibitors, wannabes, N-acetylcysteine, you need 1,800 milligrams a day. We actually get one that's 900 milligrams, so it's twice a day. But normally the ones out on the shelf is 600 3 times a day. Chrysin, flaxseed oil, nettles, zinc, 30 milligrams twice a day. And I left off here, I think did I mention saw palmetto, about 500 milligrams a day. Testicular atrophy will happen with testosterone converting to estradiol. Once you get to estradiol levels over 28, you're going to start seeing testicular atrophy. So this is another one of those. You let the estrogens run to 150. I don't know. You'll have adequate FSH as long as the estradiol is under 28. Once it gets over 30, it suppresses FSH, and it's going to suppress spermatogenesis. We notoriously don't use testosterone in young men, especially of fertility age, just for this reason. And theoretically, I don't know if I would do this, but 250 milligrams of testosterone every 4 days IM can act as a contraceptive. I don't know if I'd hang my hat on that, but someone did a study on it, and that's what they came up with. What to do for testicular atrophy? Again, weight loss, alcohol and caffeine. Don't put your computer or your phone on your lap. Without erectile dysfunction, is the same thing. You can use progesterone 100 milligrams at bedtime with some DIM. With erectile dysfunction, we'll use the very low dose anastrozole with some DIM. You can use HCG or clomiphene, of course. So HCG will restore testicular volume. Clomiphene does not affect the prostate, does not affect sperm count. And again, reduce testosterone dose. To improve fertility, go to the transdermal testosterone versus the IM. You can add some HCG, 100 to 300 units a day, or 500 to 750 twice a week. The compounding pharmacists can't make this stuff anymore, and so we only have the trade name, and it's pretty expensive. So there's a synthetic HCG, Ovitrel, 0.02 cc's per day. You can add in some zinc, at least 50 milligrams, vitamin A, vitamin E, a high protein diet. It has to be an animal protein diet. Plant proteins don't seem to do it. And again, smoking, too little or too much exercise can have an effect on fertility. 5-alpha reductase inhibitors, dihydrotestosterone and male pattern hair loss, that was studied by James Hamilton at Yale in 1947, and this is where the concept of dihydrotestosterone affecting sort of the super testosterone, so affecting the prostate, affecting the hair. It came from that study. In 1974, this Dr. Imperato McGinley went to a Caribbean island somewhere, I think somewhere in the Dominican Republic, and there's a sect there with has a 5-alpha reductase genetic deficiency, and at maturity they all had good hair. They didn't have prostate issues, but they all had behavioral issues. They all had anxiety and panic disorders, and that should have been a clue for what would happen if we use 5-alpha reductase inhibitors. But there's a lot of money to be made in them their bald heads. So testosterone is converted to dihydrotestosterone by 5-alpha reductase, and that's where you get your hair, voice, muscle growth, and prostate enlargement. Tissue dihydrotestosterone differs from scalp dihydrotestosterone. Rising scalp dihydrotestosterone is linked to male pattern baldness. That dihydrotestosterone in the scalp squeezes the hair follicles and chokes them off, and it cuts off their blood supply. Rising body tissue dihydrotestosterone dilates the blood vessels and increases hair growth. And the cutoff is about at the eyebrow. So from the eyebrows up, you're going to get decreased hair growth with increased dihydrotestosterone, and from the eyebrows down, you're going to get the exact opposite. Castrated men before puberty do not go bald. 5-alpha reductase inhibitors slow hair growth, but the hair growth recovery is incomplete. MK906 was approved in 1992 by the FDA, and it competitively inhibits type 2 and type 3 5-alpha reductase. There's three types of 5-alpha reductase receptors, and finasteride, which is this one, blocks type 2 and type 3. Dutasteride, which came about in 2002, blocks all three receptors, and it will decrease your dihydrotestosterone levels by 98%. The finasteride decreases prostatic dihydrotestosterone by 90% and the serum by 70%. The serum dihydrotestosterone, however, don't always correlate with tissue dihydrotestosterone. So I usually don't bother with those blood levels because they don't really tell us all that much. Finasteride package insert it's indicated for benign prostatic hypertrophy and androgenic alopecia. The prostate dose is 5 milligrams a day, and the androgenic alopecia growth, male hair pattern baldness, is 1 milligram per day. For females, it's off-label, 2.5 to 5 milligrams per day orally, and you can use it with an oral contraceptive. Sorry, I knocked that off. Can you still hear? Oh, there's nobody here to monitor it. Can you still hear me? I knocked the mic off. So you can use it with oral contraceptives. You can use it with, I don't know. Again, I'm going to have to hold it, I guess. You can add it if you get an inadequate response with birth control pills. You can use it as initial therapy for those females who don't want to conceive And you can also mix it with 1% testosterone gel for cellulite. It actually works quite nicely. I don't know. I knocked it off.
It happens, man.
You just wanted to get in the video.
That's right. Hello, future people who are watching this with Dr. Clearfield.
Yeah, there we go. Okay, so that's your package insert. The side effects in the package insert: infertility, 34% decrease in sperm count, 14% decrease in sperm volume after 26 weeks of use, and normalization of seminal quality returns allegedly after discontinuation. And I have to tell you that there's a small percentage, probably about 5%, where it doesn't return. Sexual dysfunction: the overall rate of sexual dysfunction is at 3.7%. And so these percentages don't sound like a whole, it's no big, we're doctors. 3% get infertility. In 2020, that was the last time I looked, there were 11 million prescriptions written for finasteride. So do the math. 3.7% times 11 million is how, 10% is what? 1.1 million. So a third of that. So 400,000 men end up trying to save their hair, end up with erectile dysfunction, sexual dysfunctions. That's a lot of guys. But it doesn't sound so. You can make statistics sound like, it's only 3.7%. Breast tissue dysfunction, 1 to 2.5%. Impotence, 5 to 8%. Decreased libido, 2.6 to 6.4%. But remember, who's taking this stuff? Well, guys our age, for prostate issues, maybe that's not all that, terrible, although, some of us are still in the game. But the 1 milligram patients are what? Ages 18 to 43, trying to save their hair, the young guys. And that's really where, the side effects for this can be quite devastating. Here are lab value on average after using finasteride, 5 milligrams for 6 months. You're blocking 5-alpha reductase. It's got to go somewhere, right? Again, so where does it go? We'll get a 15% increase in estradiol and testosterone, and so that whole pathway sort of just backs up. Okay, pregnenolone, vitamin D also. You get an increased insulin resistance, increased fasting blood sugar. You'll get a decrease in progesterone by 90%. Dihydrotestosterone, 60 to 98%, depending on which preparation you're using. You get a 50% decrease in PSA. So they're on finasteride, and you do a PSA, and the PSA used to be 1, now it's 2. It's really 4, right? You'll get a decrease in FSH and LH. You'll get insulin sensitivity. You'll get issues with allopregnenolone, GABA, and semen analysis. Got it? Okay, so this sort of syndrome has come about called the post-finasteride syndrome, and a lot of the urologists at first poo-pooed it and said, there's no such thing, and it's in your head, and it's an internet thing. But we've showed you some of the pathways 5-alpha reductase uses, and it's the real deal. So, and again, even in the package insert, you get decreased semen volume, semen force, loss of spontaneous AM erections, you get penile shrinkage, sexual anodidia. This one you see quite common with the guys who've been taking, the young guys with finasteride. You get some scarring tissue, erectile dysfunction, and loss of libido. General symptoms. So when you see general symptoms, I want you to see if you can put together the, connect the dots. So general symptoms: gynecomastia, increased fat deposition, increased obesity, increased weight, decreased body temperature, dry skin, dry hair, decreased oiliness in the scalp. What is that? But no, even more specifically. That's thyroid insufficiency, right? Right? Dry skin, dry hair, dry nails, thinning nails, increased fat deposition, increased triglycerides, and this was the body temperature. So the body temperature never goes above 97.6 Fahrenheit. Okay, so So during the lockdown, my father was over at a personal care home, and every time I had to go every day. I had to go take him out and take him for a ride, and they would take your temperature when you went in there, and if you had a high temperature, I guess so. I was always low. I was 97.1. I was 97. One time I was 96.9. I said, do it again. It was probably right. So turns out I have the Reno hypothyroid disease. I didn't have it when I got there. I have it now. So it seems to be epidemic there. So again, general symptoms, again, and you were right about testosterone symptoms also. Gynecomastia, increased weight, increased fat, so that's the other one. So these are symptoms of hypothyroidism and hypogonadism. And then there's the mental side effects, and this was the most controversial. The companies that make it and the spokespersons for them, they denied this, from stem to stern, but there's been too many cases of it. Memory recall, anodidia, again, emotional flatness, insomnia, anxiety, depression, impaired problem solving. And they said, and it happens more in the 1 milligram patients, so the younger guys than the older guys. And they said, well, that's not possible. How can you have, the higher dose you should be worse, right? Well, there's plenty of examples where the higher dose is either acts differently or is actually better than the lower dose, okay? Low dose naltrexone, for one. Pretty much any of the antipsychotic medications, the higher the dose you see at the lower doses, that's when you get the tardive dyskinesias from the antipsychotic medications, not at the higher doses. I showed you this again. So this is, again, this pathway. So this is the one, they showed you that big fancy chart, and the testosterone, the dihydrotestosterone, 5-alpha reductase is the enzyme that converts testosterone to dihydrotestosterone. But the so-called hidden pathway, the one that's really not looked at very often, and we alluded to this a couple times today already, even earlier today, when you convert cholesterol to pregnenolone and pregnenolone to progesterone, progesterone converts to 5-alpha dihydroprogesterone. Testosterone, dihydrotestosterone, progesterone, dihydroprogesterone. It's the same enzyme, 5-alpha reductase. We block that out. You block the pathway that stimulates allopregnenolone. Allopregnenolone is the hormone that stimulates GABA receptors. GABA is your calming neurotransmitter. And when you block that out, you're going to end up with agitation, irritability, and all the rest. And so this is just another schematic of that. So 5-alpha reductase, progesterone to 5-alpha dihydroprogesterone. Block this out, you're going to knock out your allopregnenolone. Now it happens in maybe 1% to 2% of the patients, but for some of them, have you dealt with anybody who's had this? Some of them have taken one pill, and that's all it took. So again, if they're on, if you're prescribing this stuff, just be aware of it. Be aware that it can happen, and be very careful, especially with patients that are they come in and they're pre-exposed to either depression or some sort of they have some sort of family or mental condition, because this is pretty devastating and it's very difficult to reverse. It's young guys, and they'll do pretty much anything. So diminished allopregnenolone again decreases your GABA, your calming neurotransmitter. These are the symptoms of decreased GABA, and here's your mental psychiatric issues that come from post finasteride type issues. So again, memory loss, slow thought process, increased aggression, decreased comprehension, anxiety, suicide ideation. There have been 80 suicides that have been traced back to beginning with 5-alpha reductase inhibitors, insomnia, and emotional flatness. I mean, guys, taking a pill to keep his hair, and he ends up, kind of a mental basket case. That's kind of not great. A word on suicide: men ages 18 to 45 between 1998 and 2013, 1 milligram of finasteride for 6 months, 4,900 adverse reported effects with low-dose finasteride, suicide ideation rate of 0.7%, 87% of those had concomitant insomnia and depression. 12% of them had persistent sexual dysfunction, 8% harbored suicide thoughts, and 15% completed suicide. So you get some hints here of who to be careful with the 5-alpha reductase inhibitors. Pre-existing depression, pre-existing insomnia, anyone who's got some sexual dysfunction before they start taking these medications, and anyone who's had suicidal thoughts. You should probably stay away from this stuff. There's all sorts of court records that are going on with this. So 700 reports of suicide ideation from 2011 to about 2022. This is actually higher now. Suicide was more common with the lower dose than the higher dose. The manufacturer have said, so, well, you know, these guys will have hair loss, so they have low self-esteem. That's why they kill themselves. So, and they're depressed. It has nothing to do with us. I showed you this earlier, which test to use: total testosterone, free testosterone, the bioavailable. We like the free androgen index. An average production of testosterone in men is anywhere from 4 to 5. I showed you 5 earlier. 4 to 5 milligrams to 12 milligrams per day. So 28 to 80 milligrams per week. So the guy's getting 200 milligrams IM over a short period of time. They're going to be overly treated. So you're going to get super physiologic doses. This is kind of a table of what's available. Some of these are brand names. I guess I'm not supposed to show you that. So clomiphene we use in young guys. Clomiphene, 50 milligrams will increase testosterone, total testosterone levels by about 50%, one tablet per week. So 2 tablets per week will double your testosterone levels, and it'll follow usually with the free testosterone also. The issue now is that after the lockdown, the generic clomiphene manufacturers all closed shop and left town, and all you can get on the commercial market now is the brand name. The brand name can go anywhere from $10 to $20 a pill. We do have some compounding pharmacies who are making off-label and off-dose brands, 45 milligrams a pill, 48 milligrams a pill, and we can get them for about $2 a week. I can tell you where after we stop filming, where to get it. So, okay. We really don't like the testosterone, the commercial products that are the gels and the patches. They're synthetics. We see all sorts of side effects from them. We try to stay away from them as best we can. And they're very expensive too. You know, this one you'll get, if your insurance will pay for it, they'll pay $75 a month, and they're over $400 a month for this one here. I think this one's not available anymore. We use the commercial Cypionate, and again, usually anywhere from 40 to 100 milligrams a week. We'll sometimes split the dose. You'll get a steadier state that way, so you don't get that surge and then it falls off by the end of the week. So we'll split the dose. I don't use those big needles. They tell you need an inch and a half needle to jab it into their leg or into their buttock. I think whoever made that up was just being sadistic. You don't need that. A 25 gauge, 5/8 inch needle is more than enough to get adequate blood levels. We've been doing it for 20 years. I've never had a problem with it. The CVS particularly likes to annoy you with, this is not right and that's not right. And I've taken to putting right on the prescription. This is the right needle size, and we get adequate levels because. It's just maddening them. We do pellets. We like pellets a lot. Some don't. So pellets are bioidentical compounded testosterone. It's pure. We've been using the same outfit for almost 20 years. We rarely, if ever, have a problem with it. They moved, unfortunately, from Las Vegas to Florida, their manufacturing plant. And so sometimes we get a disruption because there's hurricanes or there's a shipping problem. There's somebody's on strike, that kind of thing. But they're very reliable. You'll get a steady state. They're coated. They have little tiny pinholes in them, and you'll get a steady state testosterone amount. On average, you want for guys to be using about 10 milligrams a day. So if you use, they come 200 milligram pellets and 300 milligram pellets for guys. The 300 milligram pellets are pretty big, so I don't use those. So on average, you'll use maybe 6 of them, so 1,200 milligrams to 1,400 milligrams. And again, on average, if you use 10 a day, the pellet should last anywhere from 120 to 140 days. You can pretty much rely on that. Everybody has a different reaction to it. Some of them, they're sensitive to it. They need less, some need more. You're not going to know it until they use it. But that's pretty reliable. For females, we do about 1 milligram per day. So 100 milligram testosterone pellet should last about a little bit over 3 months. On average, we start on the lower end. About 150 milligrams is on average, and that'll last 5 months. It's one and done. If they travel a lot, if they have little kids around, if they don't have to worry about it. They will know. Patients will, if it does run out before they get it re-upped, they will feel a difference, and they'll tell you that. And the complication rate is pretty small. I had one guy who was mad at me. We do it in the low back or in the buttock. We did it in the low back. He got in his truck and he drove from Reno all the way to Austin, Texas, and it was infected 2 days later. I mean, I don't know if that was my fault. He's driving a truck and rubbing against it. We'll either use steri strips. Sometimes we'll put a couple of absorbable sutures in if they're bleeding a lot, and we don't have to worry about them coming back for it. It's pretty convenient, and we don't have to worry about them taking it at the right time. Are they getting enough? Are they getting too much? Even with the dispensers, you can get a little bit too much, too little. Oh, I forgot it yesterday. Oh, I forgot, that kind of thing. You don't have to worry about that. There's a couple of new kids on the block. There's testosterone undecanoate. It's a pill form. Remember, we were always told not to use oral testosterone because oral testosterone, especially the methyl testosterones, the synthetics, goes through the liver, it gets conjugated, and you can end up with hepatic toxicity. So these newer ones don't do that. They get absorbed through the lymphatic system and they bypass the liver. The real problem with them is they're extremely expensive. They're $800 a month, $1,000 a month. You can compound one of these for $50 a month. So I don't really see the need for it. There's a nasal spray also, but you need to use that 3 times a day, and it's also about $800 a month. And side effects are headaches and rhinorrhea. And again, 3 times a day, you got to be shooting this stuff up your nose. I guess there's a market for it. I think I've written for it. Somebody asked for it. I've written for it once. Onset of action. The creams and gels for testosterone usually takes 4 to 8 weeks before you're going to start seeing any effects. So, they're not going to be, it's not going to be yesterday, tomorrow you're going to be better. Injectables take about 4 weeks, and pellets take 4 to 7 days. So the pellets have the quickest onset of action. You'll get a steady state, and you really don't have to worry about them, getting too much, too little, forgetting about it. Getting it on, their Rottweiler or their infant babies also. So, again, oral testosterone, it was the methyl testosterone. Never use it. I mean, don't use it. There are some sublinguals. There's some of the compounding pharmacies will make it into a liquid. I really don't know about that. I try to stay away from the oral form. The transdermal products are usually in a 1 to 2% concentration, and it's usually not enough. Usually, 1 to 2% is usually what we use for females. The male, concentrations are usually 10%, up to 20, or even I've done it 25%, but the cream gets kind of messy, and you have to find the right person, the right outfit to make it for you. Injectables, so testosterone, cypionate has a 12-day half-life, ethanate has a 10-day half-life, and I've seen, sorry, Joe, but at the VA, they'll give them, we'll give them 100 milligrams IM once a month. Then they'll move it up to twice a week. And again, most of it's run out by then, and you're pretty much starting over. You will get less estrogen conversion with a a biweekly versus a weekly injection. Some guys don't like needles. If you've done it yourself and all, you kind of get used to it. It's not that bad. There is the testosterone undecanoate injectable, which has a 12-day half-life. It's made in an oil, and it has a castor oil carrier, and you have a much longer half-life here. The way this is dosed is you do day 1, you get an initial dose. Day 28, you get another dose, and then it's every 12 weeks after that. So 4 to 5 times a year after that. The problem again, one is it's very expensive. 2, there's a risk of this pulmonary oil embolism, and you have to have the patient stay in your office for at least 30 minutes after the injection, and you have to have emergency equipment available. So again, it's $800 a shot. So 5 shots a year is $4,000, right? I mean, this stuff, you can get this stuff for 20, 30 bucks a month. It works just fine. This same thing here. Even the propionate, we can, sometimes if we're having trouble getting blood levels, so testosterone propionate has a very short half-life, and we'll do a blend. We'll either have them compounded together in a blend, so you get a short-acting and a long-acting one, or we'll do it separately, and we'll give this every other day, and then we'll give this one twice a week. And that way we'll get a steadier state level, and it'll stay that way. So you can combine them. You can put anastrozole and HCG in the syringe also. You can put zinc in the syringe. I don't usually do this. You can use anastrozole IM. Usually the oral stuff is very, simple. It's 30 bucks or 12 bucks for 30 of them at the supermarket pharmacies in Reno. And we use a half to one a week. So, more than 6 months for 30 bucks is pretty reasonable. Side effects, mood swings, variable libido, sexual function, and energy. You can get pain in the injection site. You do get the erythrocytosis we talked about, acne, non-productive cough, estrogen excess. We talked about gynecomastia. I talked about the dosing for the pellets. This is testosterone without testosterone. So again, young guys under 40, usually we will recommend the clomiphene. On average, 50 milligrams twice a week will double your total testosterone level and also your free testosterone level. And it will improve osteopenia and osteoporosis. So I just included this. This was a practice note from a endocrinologist. So I had a patient. He came in. He was 26 years old. He had gotten food poisoning in Cancun. He came to me in March, so it was over Christmas. So 2 months later, a little bit over 2 months later, and he shows up and he's got full-blown Hashimoto's thyroiditis, and his testosterone level was about 120. So we started him on some clomiphene, and we did what we did for Hashimoto's, and it got his testosterone levels up to 800. It doesn't affect the prostate, and he was doing pretty well. So he goes to the endocrinologist. I don't know exactly why, but they're the specialist. And this was the note that I got. The MRI was normal. His ultrasound was consistent with Hashimoto's thyroiditis, which I told him he had, 3 months before this note. We discussed, and listen to this carefully, treatments for testosterone. I indicated that clomiphene that he has used and has had success with is not FDA approved, which is true, and we do not know the long-term effects. Okay, you ready? Do not know the long-term effects. It took me 15 seconds. Outcomes of clomiphene citrate in young hypogonadal men. Long-term follow-up for hypogonadism is that clomiphene is an effective alternative to testosterone in men wishing to preserve fertility. Side effects was the same as testosterone. So it took me 15 seconds to find that. And mind you, he probably paid this guy 4 or 5 times what he paid me for the same visit. Right? However, it is available to him. Remember, we do not know the long-term effects. However, it is available to him and maybe most convenient. Also likely to preserve his fertility if that is currently intact. Exogenous testosterone will suppress his testosterone and spermatogenesis, which does not mean it cannot recover in the future and be stimulated by HCG. These are all unknowns. Also, it is not a good idea for young men to go without testosterone. You can feel chronic fatigue and loss of libido. I offered to send him to another endocrinologist or another medical center. I also offered to send him to a urologist for subcutaneous testosterone implants. Well, didn't he just say that was no good here? And he didn't need to go to any urologist. I've been doing testosterone pellets since 2003. I think, as my mother said, you've been doing this long enough, you should know how to do this by now. You do pellets at all? Okay. Well, if you want to learn, let me know. Okay, HCG is a prohormone. It creates an anabolic state. It preserves catabolism. It increases testosterone. It preserves testicular size, and it promotes weight loss. And did you ever do the HCG diet thing? So we did that. We can't get that for it now, and it's really expensive stuff. It decreases triglycerides. It improves your insulin resistance score. It increases fat-free body mass. It does not change your inflammatory markers or your lipid profile. It preserves a testicular volume. If the LH is less than 3, you usually get a good result. If the LH is greater than 3, you're probably not going to get very far with HCG. It measures, it needs functioning Leydig cells. Okay, HCG to preserve testicular volume, 250 units twice a week. We usually do it for IM injections on days 6 and 7 after the IM injection. So the day before and 2 days before the next IM injection. So if they give them themselves the shot on Sunday, save testosterone, we'll do Friday and Saturday, we'll do the HCG. As a standalone, you need 3,000 units every 2 weeks. We'll increase testosterone by 25% or 1,000 units twice a week. It's pretty expensive. I mean, a 10 cc bottle is 10,000 units, 2,000 a week. A bottle lasts 5 weeks, and the stuff is, several $100s. So, and you can get used to it. You can build antibodies to it. So, at 2, Joel? At 2? You too?
You'll know why.
Oh, okay. Better than me? What could be better than this? HCG side effects, and quite frankly, I don't really see a whole lot of that, but this is in the literature. Acne, hypertension, so, elevated testosterone levels. Blood clots have been reported, water retention. I've had a couple guys tell me they get paresthesias, pins and needles in their hands or feet, some ringing in the ears, dizziness. Usually if we stop it, it goes away. These are 20 ways, and I may go over this tomorrow. I may do this tomorrow because I have a whole lecture on. Did we do this last time? Were you here when we did ways to raise and lower hormone levels without using hormones? Okay. So these are 20 ways to raise testosterone levels without using testosterone. And again, lifestyle things. So high intensity and interval exercise, high protein, healthy fat diets, and the protein has to be animal protein. Plant protein does not seem to work. Stress reduction techniques, adequate vitamin D, adequate sleep. Boron will lower the sex hormone binding globulin. We told you that before. Adequate magnesium level will raise testosterone levels. DHEA is the precursor of testosterone and estradiol. Ashwagandha is an Ayurvedic herb. It will increase testosterone levels. It will increase LH, and will also increase TSH. But again, you need an adequate amount. You need 300 milligrams twice a day, which is kind of a high dose. If you look at a lot of the supplements, they're much lower. And so he said, well, they don't work. Well, because you need an adequate amount of ashwagandha. Mucuna pruriens is an herbal remedy. And again, 5 grams per day. You need an adequate amount. It usually comes as a powder. It will improve testosterone and LH levels, also epinephrine, norepinephrine, and it will actually improve sperm count and sperm motility. Tongad Ali, that's the stuff that's in the GNC that they always, I've not really had a lot of good success with that. I don't know, do you have any experience with that? But I'm really not too impressed with that one. Yeah. Myomin is a Chinese herb. It comes from the Qi Chinese Herb Company. It comes in a pill form, 500 milligrams twice a day. We have used this. It does act as a bit of aromatase inhibitor, and it will increase testosterone levels over 6 months by maybe 15 to 20%. That's a pill. We don't really see too many side effects from it. Zinc in a pretty high dose will increase testosterone. That's 250 milligrams a day. That's a pretty high dose. Pomegranate juice and pumpkin seeds, we'll recommend those. You know, those are easy. But again, when pomegranate juices, you have to get real pomegranate juice, not juice cocktail, which is a lot of what you see. Chrysin will act as an aromatase inhibitor. Shatavarti is another Ayurvedic herb which increases testosterone and sperm count. Maca is around quite a bit, and it will increase libido and improves erectile dysfunction. It doesn't really change testosterone levels too much. And selenium, which is, you know, you need for thyroid metabolism, will increase sperm count and normalizes sperm motility. It will also decrease thyroid antibody count also. This is just a chart of all of those with the doses. So if you want this, you know, you can stick it by your desk side, and that'll give you want to get that picture there, and that'll give you just what we use in the doses. Remember, the boron is for the high sex hormone binding globulin. Got it? The tests again, it looks like I got a repeat here. Okay, we did all this, right? Am I going backwards? Okay. This is the second chart here. And again, like I said, Tongat LE, I don't really have had a lot of good success with that. You want that one? These are the references here. So then let's put it all together, okay? So chronic inflammation, nutrition, hormone restoration, and mind-body balance. So that's kind of like the whole program. Okay, here are the lab studies that we do. If you want to get that, you probably, I mean, you know this, right? Got that? Yeah, these are some of the advanced lab studies we'll do. So these aren't the initial ones, but we'll frequently go to these. So IgG, food allergy, food sensitivity, I really should say, testing. Functional GI tests, there's many companies that make it. So we're looking for bacteria, viruses, bacteria, parasites, and yeast infections. SIBO, which is small intestinal bacterial overgrowth, Lyme antibodies, and mold and mycotoxin testing. So there are two camps now in the mold and mycotoxin testing. The traditional one is they use urine tests, and they'll use binders. And then there's another group that says the urine tests are no good, and you only get it from a serum test. You need an IgE and an IgG, and they test 12 different mycotoxins for both.
Testing like the Lyme antibodies and the mold mycotoxins. When you initiate therapy?
Well, it depends. You know, if they have some symptoms, you know, a lot of these people, by the time they get to me, they've been to 47 other practitioners. And so a lot of stuff's already been ruled out. So then it makes it a little bit easier, actually, because they say, okay, well, let's try this. Okay. So I've been working on a whole presentation on mold. I didn't quite get it finished for this, so I'll try to get it next time. But there's like 20, disparate symptoms for mold toxicity that are, none of them are specific for anything. Brain fog, seizures, new onset seizures, unexplained weight gain, joint pain, all sorts of non-specific things. So I'm getting better at it, though. So the last 12 mold tests I've ordered, I've had 10 positive ones. So I'm getting better at it. You can go online here to survivingmold.com. This is an eye test, and you can do it for free. And it'll give you an idea if there's been some retinal. So the mycotoxins go to the retina, and they damage the retina. There's like micro damage in the retina. And so this VCS aptitude test, you can do it for free, or if you want a reading, it costs $15. And you can do this, and it'll give you at least an idea that there might be some mold damage. This ERMI mold test is another one. IgE and IgG antibodies, that's the one that I kind of use now. It is a little bit expensive. It's $380 for that test.
Local lab do it?
The local labs will do, sort of the basic stuff, but they'll give me, this one will give me which mycotoxins are, will turned up positive. So it'll be much more specific. Lab calculations. So if you're lost in all of this because there's too much to go by, so I do these calculations for all of our patients. So we talked about that reverse T3, that inert T3. So the free T3 to reverse T3 ratio. Normal is greater than 1.06. We like it greater than 2.0. That's pretty much what we consider normal. Elevated reverse T3, most of the time, 90 to 95% of the time, it's from abnormal cortisol, either too high or too low. And this is what I use as my screening test for cortisol. We used to do the saliva test just pretty much on everybody, but and it's perfectly fine, except again, it's $250. No insurances will pay for it. It's more useful for telling me where the changes are during the day and when to dose what were our interventions, I think, than telling me, yeah, it's positive or negative. I mean, if it's equivocal, that's one thing. But we really find the reverse T3 is pretty accurate. Anytime it's over 15, they usually have the symptoms of cortisol abnormalities. Some of these other things, low ferritin, B12 deficiency, you'll have this, but like I said, mostly a high reverse T3, I just think of, it's a cortisol issue. TSHI index is a way to look at low TSH, which remember it's an inverse, so low TSH, it means you're hyperthyroid, but low free T3. And we see this quite often. So a low TSH, this one here is 0.875, a low free T3, and that'll give us you take the TSH, add 0.1345 of free T4, and that's your TSHI. We want it to be greater than 1.3. If it's less than 1.3, this is a brain issue. We got a neurodegenerative issue. If it's greater than 4.1, it's a peripheral issue, either cortisol or some sort of thyroid abnormality. Okay, so we use these calculations to, especially if we're sort of lost, or if you're like me, you're busy and we have to get to the next one. This will give you a good idea of what to do, what to look at when the TSH is low and the T3 is low, right? If you have a 0.875, this should probably be about 3.6, 3.7, right? If you were functioning correctly. Insulin resistance, I mentioned this earlier. Fasting blood sugar times fasting insulin, and to get the correct units is 405. Normal is less than 2.9, or optimal is less than 1.9. Insulin resistance is independent of hemoglobin A1C. Future glucose abnormality risk, for every point over 84, there's a 4% increased risk of glucose dysfunction within 5 to 10 years. And I gave you that same example as earlier. At 94, fasting blood sugar at 94 has a 40% chance of increased incidence of glucose dysfunction. And what I didn't have in the other one, here's the reference for that here. Okay, so, and that was 2015, so that's not all that new anymore. Free androgen index, total testosterone divided by the product of the sex hormone binding globulin times 0.288, that'll get us the correct units. Normal for males is 30 to 130, optimal is 52, 53 to 107. For females, it's 0.4 to 8.4 of normal, and optimal about 2.9, say 3 to about 6. Okay, bioavailable testosterone, that's takes into account the sex hormone binding globulin and albumin. There are calculators, you go online and just type in bioidentical hormone, or bioavailable testosterone, and one of them will come up. But you need all of those. You need all of those parameters. This is a chart that we kind of use. We'll fill in the blanks, fill in the patient's numbers for female, for male, and that's our hormone stuff. Are we good, or you want to keep going?
Pardon me?
Are you good, or you want to keep going?
Whatever you want to do.
I don't know what, huh?
Well, good with me.
Okay,
I don't know, you want to take a break?
5:30. I don't know how to turn that off though. That's the thing. So I'm good. We'll go to 6 if you want. I think we should be able to finish it by then. Okay, so obviously nutrition is a thing, and there's lots of diets, there's lots of fads, and this is sort of an age-old thing. So the ones that we like, we've sort of come down to. If the patients have any type of autoimmune issue, we'll do the we have an autoimmune protocol. I'll show you what that, just an outline of that. Keto diets, paleo diets, Mediterranean diets, those are pretty much our staples. Gluten-free, anybody that has a thyroid issue, with immune issues or not, I mean, we encourage them to do a gluten-free diet, and I tell them it's the Judge Judy deal. It's a yes or a no. They're either doing it or they're not. Not 90%, not 95%. It's either yes or no. Some will listen, some won't. I know it's not easy. I mean, I have a hard time myself, but especially if they're sensitive to gluten. If they want a gluten test, we'll send it for them. But quite frankly, they're kind of useless. I mean, if we go out and have a pizza and a beer, and you're sick for the next 3 days, and we send you for a gluten test, and it's normal. I mean, what. And if it happens once, okay. But if it happens continuously, I mean, you're sensitive to gluten. I mean, what do you want? So the latest kids on the block are the GLP-1 agonists, and if you want, tomorrow I have a whole lecture on them and how we've been using them. And then there's intermittent fasting also. So those are the hormones. So hormones we talked about. This is a chart that I made. It's pretty much gives you all the functions, what happens with deficiencies, and there are the doses here. So we have them all here. I got 20 years of study. There it is in 2 slides. Couple of cases. So 52-year-old male, primary hypogonadism. So this is your typical guy. He's Archie Bunker. He comes in. He's got a big fat belly. He lays on the couch and watches TV. And the wife's disgusted with him and says, "Do something or I'm leaving." Low libido, persistent fatigue, decreased concentration. We did our workup. This guy is total testosterone was 198. Free testosterone 0.7. The free androgen index was 18. Remember, we're looking at 30 to 100 and 130. I'm not sure where this range came from. His estrogen was high at 62. According to the AMMG guys, that's perfectly fine. And his vitamin D was 19. With a lot increased body fat, especially belly fat, you're going to get a higher estrogen level. So, a pretty typical case, right? So, okay. So, what would you do here? Mm-hmm. Yeah, I would use. I would use a Arimidex. I would use that. 1 milligram a week. We would get them some testosterone. I might do 100 milligrams IM weekly if they want a cream. Usually we start at 10% and we'll go up to 20%. We'll give him start at a half gram at 10% a week. If he wants pellets, we'd start maybe 1,200 milligrams. That should last about 4 months. And if clomiphene doesn't seem to work as well over age 55. And again, if the LH is high, it's not going to help us either. But again, clomiphene 2 tablets a week will double the rate. So I usually don't go more than 3 in a week to start. So if he's at 198, say 200, that'll get us to maybe 500. Not bad, at least not a bad start. And then you can add in some, have them come. We'll see him again in a couple months down the road, and we can add in like an IM testosterone with that. We'll also get him some vitamin.
Tell them to be consistent.
Right. Yeah. Well, that's the problem with the shots and the cream. The pellets, you put them in, and then you're good to go. His vitamin D level was 19. Our goal is really, our goal is 50 to 80. For every 1,000 units, that's the way that, they come in 1,000 units, this number should go up by about 8 points. So if we send them to the big box store with the 2,000 unit, 1,000 pill bottle, so 2,000 units, 2 times 8 is 16, and 19, that'd get us to 35. That would get us to normal, but not really optimal. 5,000 units, 5 times 8 is 40, and 19, that's 59. That'll get us pretty close to where we want to be. Midpoint is 65. 6,000, 6 times 8 is 48, and 19, that's 67. So there's your answer, 5 to 6,000 units. We use it at bedtime. It's a pro-hormone. It aids cortisol and growth hormone in their production. It is a bit of it's a bit of a sleeping aid. It's not a sleeping pill, but it's a sleeping aid. So we like to dose it at bedtime. Rarely someone will say, well, it keeps me awake, so then we use it during the daytime. There's a 50,000 unit once a week time release D2. We do use that. It's pretty inexpensive. It's like 50, 60 cents a pill. And so we will use that. It doesn't translate exactly. That's 7,000 units a day. So 7 times 8 is 56. But it usually doesn't get up that high with it. But it'll pretty much get us into the range where we want to be. So, okay, next case, 58-year-old male, hypogonadism. He's been on testosterone for 9 months. His testosterone went from 293 to 746. Now his red blood cell count is, at 55, and he's got some oily skin. His PSA levels went up a little bit. Mood swings and aggression. Referral to a mental health agency if necessary. But gynecomastia. If he gets this, again, we can adjust the doses. If he does not have erectile dysfunction, we can add in some progesterone. Usually we'll use progesterone cream. If he does, we'll use the tiny dose anastrozole. We'll use a half a pill a week, a quarter of a pill a week. That usually takes care of that fairly quickly. You can lower the dose, especially with fluid retention. And with infertility, you'll want to switch to either clomiphene or the HCG. Case 3. Prostate issues, 67-year-old male with prostate cancer, and we talked about that a little bit. PSA went from 0.8 to 3.9. The free PSA is greater than 21. Testosterone therapy in men with a history of prostate cancer has been traditionally, again, been contraindicated, but we already discussed that, that's really not the case. Just be careful with the testosterone, follow the PSAs. And it may be prudent to hold off on testosterone therapy until you get the prostate cancer under control. It can wait 6 months. That's the same thing. Okay, I showed you this earlier. And case 4, this guy's got Michiganosis. He's got everything wrong with him. He's got hypogonadism, heart disease, high blood pressure. He's had a heart attack, strokes. BPH, high cholesterol. He's on a whole slew of medications. The testosterone, there might be some drug interactions there. I really don't see it with that. It can exacerbate the prostatic hypertrophy symptoms. I think we pretty much, we're pretty comfortable with that. Doesn't seem to be any drug-to-drug interactions. So I think we're okay there. I do have a handout. If you want it, I can send it to you. It actually looks like this. It's an 8-week mind-body program. I don't have to hire somebody. I send it to the patient online. They fill out goals and action steps in these areas here. So family, spiritual, education, finances. We have an online program that we use for diets. It'll send patients, and you name the diet, it's already programmed in there. It'll send them recipes, menus, shopping lists, weekly, menus, and it'll last anywhere from four weeks to up to 9 months. And they'll get an email every day. Most of them are sick of it after a while. But again, it makes it pretty easy for us, and we can show, we have online diet. We're telling them exactly what to eat. So It's good for documentation. In the real world, I'm not so sure how practical it is. Sometimes we'll do some injectables. MIC is B12 with methionine and acetylcholine, or the precursors of growth hormone. Also, Myers cocktail sometimes we'll use an IV, or an IV glutathione push. And remember, I came from Wilkes-Barre, Pennsylvania, so somebody to get out to walk for 10 minutes, 5 days a week, that's a monumental, Herculean task. Moment of gratitude, buy some flowers, keep the house nice. This is the second week. This is probably the most important one. You rate yourself on a scale of 1 to 10 in 16 different categories, all of these here. Rate yourself here, and then follow it along every 4 weeks. Have them go back, and I have them send me a copy of this, and I have it in, the number of patients here, I have it in a file on my side desk drawer, and I'll pull theirs out and say, okay, fill this out now when they come in. And it gives them at least, some of them, yeah, okay, we can make a difference. Everybody, no. So the arts, hobbies, adventures, giving back, and again, on a scale of 1 to 10, rate each category, and sometimes it's a help. So we have action steps for week 2. Week 3, what do I want to be when I grow up? And pretend it's 6 months in the future. What did you do in the last 6 months to make yourself better? Pretend it's 5 years from now also. So again, these are little, psychological exercises. And I have a whole booklet here. And we send this to the patients, when they sign up with us. And a bucket list. And week 6, this vision. We have them write a letter to themselves and put it away, or some of them will give it to me and I'll send it to them in 6 months. Write yourself another letter and pretend it's 5 years from now. And action steps, and then you'd start the whole process over again. What are you going to do in the next 8 weeks? It's not a big intellectual, exercise, and it's not a big psychological thing, but, it's fairly easy to do. And it gives them something else, sort of another exercise. And then you're just giving them, semaglutide, phentermine shots, and you don't do anything else. Well, we have pretty much everything covered. Okay, so nearly everything we learned about testosterone in medical school was wrong. Cardiovascular protection, gynecomastia is pretty rare and is very easily reversible. We do not get polycythemia vera, we get erythrocytosis. Sleep apnea is pretty rare. Testicular atrophy, if they have erectile dysfunction, we give them progesterone and DIM. If they do have erectile dysfunction, and estradiol and DIM. Prostate issues we discussed. Fluid retention, you really have to have very high testosterone levels. The total's over 2,400 for that, and hematocrit's over 65. There is an increased risk of blocking of osteoporosis if you block estradiol, but you have to have very low levels for a very long period of time. So we know not to do that. You can get some acne. It's more common with the patch and less prominent with the gel, and it is dose related. Prostate cancer, everything we were taught about prostate cancer was wrong. Erythrocytosis, you do not get blood clots, strokes, and then here are all the references. So, 123 references, there's more, 147. There we go. I thank my audience. Any questions?